Okay. Good afternoon, everyone. Why don't we go ahead and get started? My name is Deepan Shah. I'm the head of cardiac imaging here at Houston Methodist, and I'm going to talk today about basic principles of cardiac MRI. To start off with, here's an example of a typical clinical MRI scanner. This is a 1.5 Tesla scanner that we have. You can see there's a table that the patient would lay on. The table would then elevate and take the patient into the bore of the scanner itself. A few things, obviously, this is a non-invasive imaging technique, does not require the use of ionizing radiation, but it does require high magnetic fields, and we'll talk a little bit about some of the safety aspects of that later. So from a clinical standpoint, you can see here that cardiac MRI really is able to provide you with a breadth of imaging options. And throughout this academic year, we'll go through and kind of highlight how CMR is used in a variety of conditions, from valvular heart disease, evaluation of masses, vascular disease, pericardial disease, myocardial viability and scar, and RV dysplasia, as well as perfusion or ischemia testing. So let's start off with the basics. So these are two gentlemen here, Sir Peter Mansfield and Paul Lauterberg, both PhDs, who received the 2003 Nobel Prize in Physiology or Medicine for their discoveries concerning magnetic resonance imaging. And so these are really work that they did in the late 60s and early 1970s. So you can see how long it takes from the time you actually do the work until you actually get a Nobel Prize. So you have to be very patient if you're looking for Nobel Prizes. And their first thing that they did was actually cross-sectional imaging of a finger. And at that time, the acquisition time was 5 hours. You can see, as we'll show you now, the field has evolved quite significantly so that we can do the imaging in a much, much shorter period of time. Really within the amount of time that it takes, or that you can do one single breath hold, because that's obviously for cardiac imaging, that's the biggest limitation that we have currently. So here's a question for the folks that are here at Houston Methodist. I want to ask one of you to unmute yourself, maybe one of the fellows. When was the first MRI exam performed on a human subject? Was it 1969, 1980, or 1977? Any of the fellows want to mute you have a 33% chance right off the bat. I guess no.
Is it 1977, Dr. Shi?
Okay, Dixita, excellent. You're right. You got it right on. That first human MRI was performed in 1977. So it gives you an idea of, this is not something that's been around for a century. Really, MRI has only been around for the last 40 to 50 years. Another question for one of the other fellows, which is the most important element for MRI imaging of the human body? Is it oxygen? Is it hydrogen? Or is it carbon?
Hydrogen.
Okay. I'm not sure who it was that said that, but you're absolutely right. Hydrogen is the element that's the most useful for MRI imaging. Now, you can do MRI imaging with other molecules as well, but the reason for it is because if you think about it, the human body is almost 2/3 water, and water obviously is hydrogen. So protons, as we refer to it. So as a result, you get the best signal if you do hydrogen-based or proton-based imaging. But in fact, you can do MRI with other molecules as well. And what's really required to do MRI imaging, there's really two basic components. There's a magnet, which creates magnetic fields, and then there's radio waves that are transmitted and received, and then a whole bunch of processes in the middle, but that allows you to then get a nice image like we see here. And so what I'm going to do now is kind of go through and walk through the different processes that occur in the middle. And again, this, today's introduction or today's lecture is really much more of an introduction. So it's not meant to be comprehensive, but it's meant to give you a little bit of a flavor for some of the technical aspects for how MRI is done. And then I'll wrap up with some interesting clinical comments as well. So we'll go through the hardware, we'll go through MRI spins, excitation, we'll go through this MRI relaxation, the concept of T1 and T2. We'll go through, what are the steps in making an image, some important concepts with regard to K-space, and then some important MRI safety aspects. So this is showing you kind of the three basic components of an MRI system. And it's basically the main magnetic coils, and you can see that's shown in this schematic right here. So for those of you that remember that first MRI image that I showed you, the picture of the MRI scanner, the main magnetic coils are actually within this main scanner itself, what people oftentimes like to refer to as the donut. There's also gradient coils, and these gradient coils are also within the main MRI scanner. And then there's radio frequency coils. And so let's go through these kind of one by one in a little bit more detail. So the main magnetic coils, or the main magnetic field, as we'll talk about, really is kind of the defining feature of an individual MRI scanner. So another question is, what are the typical field strengths that we do clinical MRI imaging in? And I'm not going to, in the interest of time, I'll just give you the answer. It's typically 1.5 Tesla or 3 Tesla. These are the ones that are today kind of the commonly used magnetic field strength for clinical imaging. Now, there is a low field scanner as well, a 0.5 Tesla scanner. And in the past, this had been traditionally done for non-cardiac imaging. Oftentimes, these are some of these open MRI scanners that you'll see. More recently, though, there is a push to do cardiac at low field strength. And then there's also higher field strength, such as a 7 Tesla scanner. And this is an example of the 7 Tesla scanner when it was being installed in the Research Institute here at Houston Methodist. So, a couple of things about the main magnet. So it's a strong, constant magnetic field. And really, it defines the strength of the MRI system. So you can't go from a 1.5 to a 3T. You have a scanner and it's either 1.5 or it's 3 or it's 0.5 or whatever it is. Now there are some hardware versions which allow you to what we call ramp up or ramp down a magnetic field. But again, that's an extensive process that's involved to go from a 1.5 to a 3 or 3 down to 1.5. But in general, whatever magnetic field you have is what you have. Another important thing to keep in mind is that, as I refer to 0.5 Tesla or 1.5 or 3 Tesla, that's the unit of measurement for magnetization or magnetic field strength. And 1 Tesla, so this was actually named after Nikola Tesla. 1 Tesla is approximately equivalent to 20,000 times the Earth's magnetic field. So you can see it's a very strong magnet that we're dealing with. Now, the next component is the gradient coils, and there's really 2 sets, or there's 3 sets of gradient coils. There's gradient coils that are in the X, Y, and Z directions, and the main purpose of these gradient coils are to cause a slight alteration to the local magnetic field, but to do it such that it creates it in a graded fashion. So that, for example, if you have a gradient coil that causes a alteration in the magnetic field in the Z-axis, then it will cause, as you get further and further away from isocenter, a more positive or more negative alteration to the magnetic field. And this is also a function of the scanner hardware itself that you purchase. So this is one of the parameters. And if you could mute yourself, please. TMH TTN30, please mute yourself. Thank you. The units that's referred to for a gradient is basically in millitesla per meter. And again, this is a specification of the specific scanner that you purchase. And then there's another concept called slew rate, which is basically a function of how fast is it able to achieve this gradient. So as we'll touch on later, it's the ability to alter the gradients, which are essential for being able to do MRI imaging. So let me also point out that because you have gradients in 3 different directions, you can also now create a reference coordinate system. So this is, I think, one of the unique advantages of MRI that makes it truly a tomographic imaging technique, which is that as a patient goes into the scanner, you're now able to create an X, Y, and Z axis and a coordinate system so you can localize to any given specific area. And as a result, you can actually cross-reference as well. So you can see on other images where one particular imaging plane was acquired. So it allows this ability to register all of your images because you're in kind of a fixed coordinate system. So we talked about the main magnetic field, the gradient coils, and then the last thing is the radio frequency coils. And there's two sets of radio frequency coils. There's the radio frequency transmitter coils. So these are, again, coils that send in a radio frequency pulse. And so the transmit coils are generally within the scanner itself, although there are some coils that may have transmit capabilities as well. And then in addition to that, there's also receiver coils, which actually receive radio waves. So the idea is you're sending in radio waves to cause excitation of protons, and then you're receiving radio waves back, which allows you to get signal to be able to then generate your image. And these radio frequency coils are typically what you see as surface coils that you place on top of a patient. There's also a second set of coils that's in the table itself. So these are called posterior coils or spine coils. And so essentially you've got coils on both sides of the patient, on the front of the patient, as well as on the back of the patient. And you'll notice these coils tend to be flexible so they can wrap around because, again, you want the coils to be as close to the area that you're interested in imaging because that's what gives you the best quality images, the best signal. Let me skip past this in the interest of time here. And let's talk a little bit now about the concept of MRI spins. So I want you to kind of bear with me here because now we're going back to some of the basic physics. So the idea is that if there's no magnetic field, then protons are going to be randomly oriented. When you apply a net magnetic field, what happens is you cause protons to be aligned. So it doesn't mean that all the protons get aligned upright. You can see in this example here, there's some protons that are upright. There's some that are anti-parallel or down, but they're not all randomly distributed like they are when there's no magnetic field. And the idea is that as these protons spin around, the low energy state or the steady state in the setting of a magnetic field is for them to be spinning around and having a net positive magnetization vector. Although, again, as you'll recognize, there's some that are positive and there's some that are negative and rotating around. But again, the ones that are negative that are not aligned with the upright magnetic field are in a higher energy state. And as I'll talk about later, we can actually shift protons back and forth between one state and the other by applying certain forms of energy. So let's go to this here. So again, this is just a schematic which points out in a patient, if you're outside the magnetic field, then the protons within that patient are just randomly oriented. So there's zero net magnetization vector. Now, once they go into a magnetic field, in this case, we refer to the magnetic field itself as B naught, then the patient's protons actually become aligned. And so now we have another magnetization, which is called M, which is basically the magnetization of the protons within the patient themselves. And this results now, when they go into the magnetic field, in a net magnetization that's aligned in the direction of your magnetic field itself. Now, the other thing is, in addition to the protons being aligned upright, remember I talked about that they spin around. So the term that we use for them spinning around is called precession. So essentially they're precessing around in an upright position or net upright position. And there's actually a predictable speed that they spin around at. And that speed is based on this equation right here, which is called the Larmor equation. And so for any MRI fellows, this would be, classic MRI boards question is what are the components of this Larmor equation? So what this says basically is that the speed that the protons spin around at when they're put into a magnetic field is equal to a gyromagnetic ratio, which is a specific constant for any specific type of nuclei. So for example, for hydrogen atoms, for protons, that ratio or that specific constant is 42 megahertz per Tesla. So it's that constant multiplied by the actual magnetic field that those protons are seeing, which is the magnetic field strength. So at 1.5 Tesla, you just take the 42 times 1.5, and it tells you that at 1.5 Tesla, protons are spinning around at 64 megahertz. At 3 Tesla, they're spinning around at 128 megahertz. Now, so that's what's happening in the resting state once they go into a magnetic field. Now let's talk about excitation, where we can cause an alteration, or we can take the protons from the low energy state to a higher energy state. And let me show you how that's done. And that's done by applying a radio wave, what we call an RF pulse. So that RF pulse, if it's absorbed by the protons, will cause the protons to actually become excited and go out of the low energy state, which again is aligned with the magnetic field. And the strength of the radio frequency pulse that we applied is referred to as the alpha of the RF pulse, or oftentimes referred to as the flip angle. So if you look on an MRI sequence or MRI scanner, one of the parameters that you can set is what's called a flip angle. And that's just saying how much radio frequency pulse energy do you want to apply to cause the protons to go from the upright state to a certain deflection into the transverse plane. Now, if you apply a 90-degree pulse, then you take the magnetization completely from the upright all the way to the transverse plane, which is the maximum energy. Because you'll see, again, all of your signal is based on the amount of the vector of the proton excitation that you drive into the Y plane or the transverse plane. Okay, so let's keep going here. And then there's two things to keep in mind. So again, when we talk about magnetization now, initially we talked about the M as being the M which is upright, aligned with the magnetic field. But then as we apply energy, as we apply a radio frequency pulse, as we apply a flip angle, we can actually then drive a certain component of that magnetization into the transverse plane. So that's now called the MXY, or the transverse magnetization. Now, and this is an example when you do a 90-degree pulse, you basically take the entire magnetization from the upright vertical plane and drive it into the horizontal or the transverse plane. And that gives you obviously the highest magnetization, because you've taken that vector completely from being upright to 100% into the transverse plane. Now, let me just show you a schematic of exactly what this looks like. And this is exactly what's seen here, which is if you look at the start of this movie, let me go back to the very beginning, is the proton signal is upright, aligned with the magnetic field. As you apply radio frequency pulses, that causes, and you can see that white, the red line there was actually the radio frequency pulses that is pushing this magnetization down into the transverse plane. And again, with a 90-degree flip, you take everything from upright and put it into the transverse or horizontal plane. Now, we'll come back to that in a second, but let's talk a little bit now about then what happens once you apply a radio frequency pulse and you drive the magnetization into the transverse plane. It's not going to stay there. There's going to be two things that are going to happen. There's going to be a phenomenon called T1 recovery and a phenomenon called T2 decay. So let's go through and talk about these, because most of you have probably heard this terminology utilized, whether you're talking about cardiac MRI or even radiologic MRI. So what is MR relaxation, which again is T1? So relaxation is the concept that when you tip everything into a high energy state, such as a 90-degree tip into the transverse plane, the natural tendency is to regrow back into the longitudinal plane, to go back again to that resting state, which is where the protons are lined upright in the direction of the main magnetic field. And so there's a predictable rate at which this regrowth or relaxation occurs. And if I were to actually map this out over time, from the time at which I apply a pulse to tip everything down to 90, which again, that means there's 100% transverse magnetization and 0% longitudinal magnetization. So in the longitudinal plane, I start here now at 0. and over time, I'll see a recovery. And the T1 time constant is the amount of time it takes to regain 63% of the intrinsic or full magnetization. So again, this is a classic board question, which is what is T1? It's the amount of time it takes. If you take your longitudinal magnetization and you tip it to 0, what's the amount of time that it's going to take to regrow to 63% of that? And that's a T1 time. Now, you'll notice on this graph here that T1 time is tissue specific. So different tissues have different T1 times. Now, we can get into more details of exactly why that is. That has to do with the physics of interaction between molecules. But the basic concept here is that fat has very short T1 time, so has very fast T1 recovery. So from the time that you tip fat molecules down, so hydrogen protons that are within fat will recover very, very fast. Water, on the other hand, has very slow T1 relaxation time. So as a result, water, if you take that longitudinal magnetization for water, tip it down to 0, and then wait for it to recover, it's going to take the longest amount of time to recover. And to give you an idea of what the T1 times are, for fat, the T1 time is typically on the order of about 200 to 250 milliseconds. For water, it's on the order of 2,000 to 3,000 milliseconds. So it's almost a 10-fold longer T1 relaxation time for water than it is for fat. And then in the middle here, you'll see normal myocardium or myocardial infarction after you've given gadolinium contrast. And we'll talk a little bit more about gadolinium contrast later on as well. Okay, so let me go over again what we just talked about, which is that over time, after you apply an RF pulse, which again takes the protons from the resting low energy state, which is upright, into a higher energy state, which basically tips them down into the transverse plane, over time, they'll regrow magnetization. Now, there's another thing that also occurs, which is that in the transverse plane, you actually get a gradual loss of signal. So you get regrowth of signal in the longitudinal plane, and you get a loss of signal in the transverse or the Y plane. So that effectively you're going back again to the steady state, which is that everything is just upright with no transverse magnetization. So this loss of signal and loss of coherence in the transverse plane is what's called dephasing. So that's a reduction in your magnetization vector in the XY axis. So this diagram again shows that as you've tipped everything down, notice what's happening. Everything is starting to spread out. And as a result, if you take the net magnetization vector, when you summate all of these together, it will be gradually less and less and less. And the best way I can describe to think of this is if you think of like the Boston Marathon or something, when if you look up from the sky, at the very start of the race, you've got a huge pack of all of your protons or all of your people lined up all at one location, which is a starting line. The longer you wait, they gradually spread out. So as you look up from the sky, you don't see the big mass of people like you would at the very start. And that's what's happening, is that because these different protons are spinning at slightly different frequencies, they all start to get what's called out of phase with each other. So they're not all running around together, but they start to separate out a little bit. And so again, you can measure that, the rate of that loss of that coherence over time, which is shown here on this axis, which again, the x-axis here is time. So it's time after when you applied an RF pulse to get your magnetization to the transverse plane. Over time, it becomes gradually less and less out of phase with each other. And the T2 is what's measuring this rate of decay. And so your T2 relaxation or your T2 decay time is the amount of time that it takes to drop your magnetization to 37% of what it was when after you first applied a 90-degree pulse. So again, T1 is to regrowth of 63% of the intrinsic magnetization. T2 is decayed down to 37% of the intrinsic or full magnetization. So again, these are two important concepts that I'm sure would get tested on MRI boards for anybody that's planning to take those. The other thing also, just like T1, T2 is also tissue specific. And you'll see that T2 or that water has the slowest T2 decay curve versus something like fat, which has a much faster T2 decay curve. And again, if you were to actually measure the times, the T2 decay time for fat is about 84 milliseconds, whereas the T2 decay time for water is about 1400 milliseconds. So quite a substantial difference. And again, since these properties are unique to different tissue, you can now do imaging, which is designed to probe specific tissue characteristics. So for example, if I do a T1 weighted image, as is shown on the left-hand side here, then this will make anything that has a very short T1 or fast T1 recovery appear bright, like my fat here, versus something that has very slow T1, like water, would appear dark. Now I could take the same exact structures, but if I do imaging using a T2 weighted sequence, then what I'll see here is that water, which has very slow T2 decay, would then have high signal on T2 weighted imaging. So as a result, I can image the exact same thing and I can make it look different depending upon what imaging characteristics or imaging sequence I utilize. And so this is really the concept of being able to do tissue characterization by simply saying, okay, I'm going to do a specific location with a T1 weighted sequence and then do it again now with a T2 weighted sequence. If it's water, it should be dark on T1 and it should be bright on T2. So that's how you kind of triangulate to say, okay, what tissue is it that I'm dealing with for a specific region that I'm interested in interrogating. Now, one thing though, obviously is, just as you can do T1 weighted imaging and T2 weighted imaging, there's a variety of other types of imaging you can do. And so as a result, you can think about it, the permutation of the number of, for any given anatomic location, the number of different types of imaging sequences you can run is almost infinite. And as a result, you can't do everything. So you have to pick which ones you want to do and which slice locations you want to do it in. But this is what makes MRI fundamentally slower. It's the ability to do this multidimensional imaging, which is the strength of it, but you've got to pick what you want to do, because if you did every single thing at every single location, you'd have a patient in the scanner for 24 hours, and that's just not practical. So let's talk a little bit now. So we've gone through some of the basics. Let's talk a little bit about how we kind of manipulate the system to try to actually make an MRI image. And this now gets to what the purpose of the gradient coils are. So the gradients really cause a local alteration to the magnetic field. And as I said, remember, there's three sets of gradients. There's an X, a Y, and a Z gradient, which means that you can alter the magnetic field differently in each of those three axes. And so the purpose of using these gradients then is to do really three steps. One is to select a slice of interest. Two is to do something called phase encoding. And then three is to do something called frequency encoding. And we'll go through this quickly. So the first step is I pick the slice that I'm interested in imaging, right? So on the scanner, right, all you're doing is you're moving a mouse, and I can say either I want to image here in the chest, or I can move the slice up higher, image up in the head, or whatever location that I'm interested in imaging, I can image. So when I do that, when I pick a specific slice of interest, how is the scanner able to specify that slice of interest? Well, what happens is there's a gradient that's applied, which in this case will be in the Z-axis. So for this patient in the head to foot direction, that gradient then results in a slight alteration such that beyond this location right here to 0 point, what we call isocenter, the local magnetic field will be slightly higher. And in the foot direction, it'll be slightly lower. So to give you an example, if this is a 1.5 Tesla scanner, then at isocenter, the magnetization will be 1.5 Tesla. But up here, maybe it's 1.501, 1.502, and it's even smaller orders of magnitude than that. But I'm just using it to give you an example. On the flip side, if you go down towards the foot direction, your magnetization may be 1.49, 1.48 Tesla. The importance of that is once you cause an alteration to the magnetization, that means now the protons higher up, the protons in the head, are going to be spinning at a different frequency than the protons in the feet. And so, in fact, the protons all along the body will be spinning at slightly different frequencies, either more positive, meaning higher than the intrinsic 64 megahertz, which is at isocenter, or lower. And again, the further away you are from the isocenter, the faster the frequency will be. The further you are away in the foot direction, the lower the frequency will be. So as a result of that, now by applying this gradient, I know that protons spinning at this location are a little bit different than protons spinning here as far as the frequency. So when I apply a radio frequency pulse, I can apply a pulse at a set frequency so that only those protons get excited. So if I'm interested in imaging a slice right at isocenter, then I would send in a radio frequency pulse that's exactly at 64 megahertz. If I want to go a little bit more towards the head, I would use a radio frequency pulse that's a little bit higher. Now, we don't have to figure this out. The scanner does all of this for you automatically once you just prescribe a line to say, I want to image at this slice location. So again, that's using the gradients, and it's relying upon this Larmor equation, which basically says that the protons spin at a rate which is directly related to the magnetic field. Okay, so let's keep going. And the other thing also I think is important to keep in mind, and I'll show this again, is because if I apply a certain frequency of RF or radio frequency pulses, only the protons that are spinning at that frequency will pick up that radio frequency transmit pulse. And the idea behind that is if you have somebody on a swing and the swing is going back and forth at a certain rate, if you push it synchronized with that, the energy from your push will go to the person on the swing and will cause the swing to pick up energy and go faster. But if you're pushing at a different frequency than what the swing is going at, then in fact, you won't make contact. As a result, there will be no energy deposition to your swing. It's that same basic principle. Okay, so next, let's go now to the two other gradients. One is what's called a phase encode gradient. And this causes the protons, again, to spin at slightly different frequencies, but in two different directions. And this is a little bit more complicated of a concept. Just kind of bear with me as I try to walk you through it. The idea is that if I apply, now once I've picked the slice that I'm interested in imaging, now within that particular slice, I'm going to apply now two additional gradients in the X and Y direction. And the purpose of those two additional gradients is that in the phase direction, by applying a gradient, protons that are at one location, which have a slightly different magnetization than protons at another location, will spin slightly differently. And when I image at a certain time point, they'll all be what's called out of phase with each other. So you can see here, in this case, the protons are vertical. In this case, they're a little bit off. And in this case, they're a little bit off as well. So the idea is that the net shift that occurs with the proton phase is predictable based on what the gradient that's applied. And then the last, let me skip past, let me go forward here for a second. The last one then is in what's called the frequency direction, which is that in the same way, if I have a gradient in a different axis, in the x-axis, it will actually cause the protons across this axis to all spin at slightly different frequencies. So when I receive signal back, then based on what frequencies I receive back, I can use that information to localize where a signal is coming from in the x-axis. So you really use this phase and frequency encoding to then actually generate an image. But the way that you do that is using this concept called K-space. So K-space is basically a plot of phase and frequency information, which you then apply a Fourier transformation to this to actually give you then an image. Now, a couple of things to keep in mind. So this is where MRI maybe is a little bit different than other imaging techniques, because every line of K-space is going to somehow contribute to your image. But you'll notice there's the center lines of K-space, which give you more information about image intensity, but not as much about image detail. And then the peripheral lines of K-space, which give you information about image detail. So you see fine lines, but you don't have any difference in image intensity information. And it's obviously when you sample everything and do a Fourier transformation and generate an image where you get both the fine details as well as you get differences in contrast between different tissues. And so another important concept then, and this applies for cardiac imaging, is as a result, if for for during the time or the lines of data that you utilize to form your image, if there's some errors that are occurring or some differences that are occurring, then that can lead to a corruption of the entire image. And so in this case, what's happening is during the time that I'm acquiring my data, the patient's not holding their breath completely. And as a result, you can see it doesn't lead to just one localized area, but in fact, it leads to kind of a distortion of the signal throughout the entire image. So that's what happens when you have a breathing artifact. So now let's go back to how we utilize MRI clinically to generate all these different images. And again, we'll go through these in much more detail throughout the course of this year. But a few things I want to highlight. One is that you'll notice a lot of the imaging sequences that we do utilize contrast agents. And so we want to talk a little bit about what are the principles of contrast and also safety aspects of contrast. Before we do that, though, a very important thing to keep in mind is the safety of or magnetic safety. Because remember, I said this is a strong magnetic field, and this magnetic field is always on, right? So if you go down on a Sunday night and the scanner shut down and the lights are out, the magnetic field doesn't go away. So you can't just go into the room with any metallic object. And this is an example of what happened when somebody, not here, fortunately, somewhere, took a patient bed into the MRI room, and you can see what happens is that magnet acts as a very strong pull to metallic objects that are ferromagnetic. And it actually, as it gets closer and closer to the magnetic field, it actually accelerates, is able to take this entire bed and pull it up into a magnetic field. Also important because if you have a patient on the table and you take an oxygen tank, for example, that oxygen tank can become a projectile. So you can have very serious consequences. And so that's why from an MRI safety standpoint, there's a few kind of important things we need to all be aware of. One is there's a safety zone designation for any MRI suite. So MRI zone 1 is basically the entrance to the facility. MRI zone 2 would be the location, the area where you actually do the screening of the patient for metal safety. So that's where you're screening to find out, does this patient have any metal objects? Do they have a pacemaker or defibrillator? Do they have any shrapnel? Do they have any history of welding or grinding where they could have little metal shrapnels in their eyes? Because you want to know about every single piece of metal that this patient may have. It doesn't mean that if somebody has metal, they can't get an MRI scan, but rather it's important to understand what they've got. And then you can do a risk assessment. And then we know that there's, nowadays, most orthopedic implants that are utilized are generally made of a material that's not ferromagnetic, means it doesn't actually pull to a magnetic field. It may cause an artifact in a magnetic field, but it won't get pulled to the magnetic field. Things like pacemakers and defibrillators, where you may need to reprogram the device before you take the patient into the MRI scanner. So there's an extensive amount of screening that happens, and that will happen in the zone 2. So the zone 2 essentially is basically a mixture of people that have been screened as MRI or have had complete MRI screening done, as well as people that have not, that are in the process of getting their MRI screening. So the reception area would be considered zone 2, as well as a patient holding and dressing area would also be considered zone 2. Zone 3 now becomes a much more controlled location, and typically there's going to actually be a lock or a badge ID that you need to be able to get into zone 3. And the zone 3 is basically the control room. So this is the area that's right next to zone 4, which is the actual magnet itself. And so really the two areas that you have to be very careful with are zone 3 and zone 4. So nobody should go into zone 3 until they've had metal screening done. And then obviously zone 4, you should only have somebody in zone 4 when there's direct supervision. So you can't, kind of take a patient and leave them on the table there for 20 minutes and go grab a cup of coffee. They have to always be monitored by an MRI trained person while somebody's inside of zone 4. Okay, so the other important thing to keep in mind, so people always ask me, is this MRI safe or MRI unsafe? The terminology is actually a little bit more nuanced than that. And so the FDA recommendation is that there's a 3-tiered system. There's MRI unsafe. So these are items that are known to pose hazard in an MRI environment. So this would be something like a pair of metallic scissors, right? Because if you take those scissors into that room, they're going to become a projectile, and if somebody's on the table, they're going to go and hit the person that's in the on the bore of the scanner. There's items that are MRI safe. So these are items that in any condition, they're going to be MRI safe. So that would be something like a plastic petri dish, which has no metallic components at all. Most of the items that we deal with are what's called MRI conditional. And what that means is that they have no known hazard with a specific MRI environment and specific conditions of use. So when we talk about things like our pacemakers or defibrillators or most other things that metallic implants, they're referred to as MRI conditional. And the idea is that they've been tested in a variety of different scenarios and found to be safe. And in addition to kind of physical testing, they've also done modeling in a series of different permutations. But the reality is you can't possibly model and anticipate or test every single possible combination because, again, this safety aspects here for any metallic object is going to be a function of both the static magnetic field as well as the gradients, which cause a local alteration in the magnetic field, the speed with which you alter the gradients, the radio frequency pulses that you're sending in, the duration of time that you're sending it in for. So there's a lot of permutations, a lot of factors that are at play. And so that's why, in general, unless it's something like plastic, where it has no metallic components to it at all, most objects, we refer to them not as MRI safe, but rather as MRI conditional, which just means that in the set of settings that they've been evaluated in, there's an acceptable risk-benefit profile. And some of the kind of classic guardrails would be, let's say, a certain pacemaker, most pacemakers or defibrillators have been tested to be MRI conditional at the 1.5 Tesla scanner. That doesn't mean then you can go and take them into a 3 Tesla scanner because you're talking about now a much stronger magnetic field. The interactions can be very different, and it certainly doesn't apply to a 7 Tesla scanner. So one of the things, though, is that as more and more understanding and more testing has been done and modeling has been done, there are more and more devices that are being labeled as MRI conditional. And nowadays, most of the device manufacturers, in fact, have pacemakers and defibrillators that are labeled as MRI conditional. Now, and so as a result, those are cases where you can scan them in a set environment with kind of precautions appropriately taken and with device settings placed in a specific manner. There's also devices that are before FDA approval was sought for certain pacemakers and defibrillators. And over time, there's been a fair amount of both modeling as well as clinical studies that have been done to really suggest that there's an acceptable risk profile to even some of the older legacy devices. And so nowadays, pretty much all pacemakers and defibrillators, with proper caution in how you do the imaging, as well as how you reprogram the device before they go into the MRI environment, we're able to generally do most pacemakers and defibrillators. For a long time, there was also concern about things like abandoned leads or epicardial pacing leads. And again, as more and more work has been done, a lot of those restrictions have also been released as well. So it doesn't mean that you can just do it and don't worry about it. You still have to reprogram the device, monitor the patient very carefully. But nowadays, most rhythm management devices are not necessarily a contraindication to MRI imaging. Okay, another important thing to keep in mind is if there is an emergency inside the MRI scanner, so if a patient's on the table and they code or they're having arrhythmias, your first job is to get the patient out of the room, get the patient out of that zone 4, out of that MRI environment, and take them back to a zone 2 area, which is basically like the holding room or the dressing room. So if they're in the scanner, we take them out of the scanner, take them out of the control room, and put them into zone 2, back into the holding area, and then you begin your resuscitation efforts. And this is very, very important because otherwise what happens, you call a code and you start trying to do something, and obviously the equipment that you have in the MRI room itself has all been checked to be MRI safe or MRI conditional. But what you don't know is when the code team comes in with a bunch of supplies, those supplies are generally not going to be MRI safe or MRI conditional. And somebody, trying to do good to help the patient could actually end up harming the patient or killing the patient. So that's why the most important thing is pull the patient out of the room, close the door, and then begin your resuscitation effort. So again, this is a little bit counterintuitive to what we're used to, which is to go and attend to the patient and try to perform resuscitation immediately. But this is very, very important, and you have to get this ingrained into your head. The other thing I want to touch on a little bit is gadolinium contrast. So obviously, gadolinium is kind of the key contrast agent that we utilize, which allows us to do MRI imaging. And it allows us specifically
How are you?
Imaging. If you could mute yourself, please.
Yeah.
Zoom in. Could you mute yourself, please?
Sure.
Thank you. So if you give a patient gadolinium contrast, that contrast will concentrate in certain areas. One of those areas it concentrates in is areas of infarction. And as a result, if you do a specialized imaging sequence, you can actually see very nicely and directly the area of infarction that occurred. And this is really a function of gadolinium contrast itself. Now, a couple of things to keep in mind, gadolinium itself is actually a very toxic molecule, but because it's bound to a specific chelating agent, that's what allows it to be safe for use. Now, there's three types of reactions that you worry about with gadolinium. There's acute allergic reactions. This is just like with anything. If there's an allergy to some component, typically it's one of the chelating agents, this can cause an allergic reaction. There's also a condition called nephrogenic systemic fibrosis, which I think we now have a fairly reasonable understanding of it and also how to manage it. And then there's the other question of this gadolinium deposition, which again, I think is an area that's not really well understood and more work is being done in. So with regard to NSF or nephrogenic systemic fibrosis, it's interesting that, although MRI imaging has been around since the late 70s, and it was, widely used clinically in the 80s and 90s, the first case of NSF was not identified until 1997. And it was initially thought to be associated with people who have advanced renal failure. And they get this condition where they get kind of a reaction where they get fibrosis in the skin and connective tissue throughout the body. It's a late reaction, so it's not something that happens immediately after they get the contrast agent, but it could be weeks to months later. And obviously, this can be very serious and potentially life-threatening. Now, as kind of more understanding from the first descriptions in 97 to the initial black box warning, which came out by the FDA in 2007 about gadolinium in patients with renal failure, there's more and more understanding that's come along. And I think the understanding we have now is a couple of things. One is that gadolinium molecule is bound to something, a proton or some other molecule. And there's two different ways, or two kind of general different categories. There's linear binding, where basically it's attached to something, and there's cyclic binding, where it's not only attached, but it's completely surrounded by a binding agent. And from most of the safety data and safety signals suggest that with stronger binding, there's less of a concern of the gadolinium agent becoming liberated and being able to cause any toxic effects. And so as a result, there's been a general shift towards more of the macrocyclic agents, although there are some linear agents that have very tight binding to gadolinium. And this has kind of led to the NSF the ACR, the American College of Radiology, more recently in coming up with kind of a risk-based classification of these gadolinium-based contrast agents. And essentially, the older agents that we had are agents that are listed as group 1 agents. These are the ones that, in fact, as people kind of dug into this in more detail, these are the ones that really had the greatest number of cases of this nephrogenic systemic fibrosis, whereas the group 2 agents, which are shown here, mostly which are newer second or third generation agents, have few, if any, unconfounded cases of developing nephrogenic systemic fibrosis. And then this other agent right here, Eovist, which is a group 3 agent, is not one that's used for cardiac imaging. So I'm not going to get into that too much detail. So I think, with nephrogenic systemic fibrosis and the the initial FDA warning that came out in 2007, over the next 14 or 15 years, significant amount of study had been done. And as a result, I think there's a better understanding of how to manage that risk. And so this is a consensus statement published by the National Kidney Foundation and the American College of Radiology. And I'm just going to pull out a couple of key things here. One is it says that the risk of NSF is different between different types of gadolinium contrast agents. And again, that's where this categorization of group 1 agents, which are the highest risk, group 2 agents, which are thought to be very low risk, and then we're going to skip this group 3 risk because, again, the group 3 is a non-cardiac application, contrast agents. They go on to say that group 2 agents should not be withheld or delayed if harm would result from not proceeding with an indicated contrast examination, that the risk of NSF using standard doses, which is typically 0.1 millimolar per kilogram, with the group 2 agents is actually quite low, even in patients with significant renal insufficiency with a GFR of less than 30. And they go on to say also that dialysis should not be indicated or altered if you're using a group 2 agent. So I think really, we've kind of come full circle almost to the point now where as long as we're using group 2 agents, even in patients with normal renal function or patients with impaired renal function, if there's a strong indication to perform imaging with gadolinium-based contrast agents, you can go ahead and proceed and do so. But obviously, be cautious about the dose that you use to try to use the lowest dose that you need, and that there's no real need to alter dialysis in these patients if they're on dialysis. The other thing to keep in mind is, there's also a iron-based agent that we can utilize called ferromoxetol. Now, ferromoxetol is essentially what's called a blood pool contrast agent. So it has its contrast effects within the vasculature itself. So it can't be used for imaging of infarction and scar like we can with gadolinium, because the gadolinium actually goes to the extracellular compartment. But this can be useful, this ferromoxetol, for imaging of vascular structures. So if we want to do a arterial angiogram or a venous angiogram, this can be very useful for that. And I've just got an example here of 2 patients, one that had lower extremity imaging done with gadolinium and one that was done with ferromoxetol. And you really can't distinguish the difference. So it gives you fairly good pacification of the blood vessels. Let me skip past here, in the interest of time, but I do want to just kind of talk about how we do imaging. So it's, again, we're not trying to worry about getting around rib spaces or getting a specific location on the patient. Rather, the patient goes on the table, and then we just move a mouse and we pick the location that we want to identify the exact imaging plane that you want to. Since you're in a full coordinate system, you can see how these different planes line up. So this short axis plane right here sits right here on the 2-chamber view and sits in this orientation on the 4-chamber view, and I can make adjustments as I need to. And I'm going to go past this because we're going to talk about this a little bit more, which is what are the parameter settings that we do when we're trying to do either static or cine-based imaging. But a few of the important parameters obviously is pixel size, and you have complete control over how high or how low resolution you want, and also frame rate or temporal resolution, and you have complete control over that. Now, obviously, to go to higher resolution, either both spatially or temporally, is going to require more time and therefore a longer breath hold time. But you can adjust these as much as you want, and the scanner will actually tell you based on the parameters that you've set what is the actual acquisition time. Okay, and so I'll give you an example now. With this ability to alter both the temporal and spatial resolution, I can get the quality of imaging that I'm interested in for any given patient and for any given structure. So I could do the same patient at 4 millimeter pixel size. I could do it at 1.6 millimeter pixel size, or I could even do it at a 0.8, right? Again, the breath hold gets longer as you go to higher spatial resolution, but you have the free choice to pick. And then I'm going to wrap up with this last slide right here, which I think kind of highlights nicely the fact that this is the exact same location, but you can image using different sequences. And as a result, you can make the image contrast look very different. And you use these properties to try to identify tissue characteristics when you're doing MRI imaging. And so I think, you can almost think of it as like MRI scanning is almost like conducting an orchestra. You've got a series of tools or instruments, and you can play them in whatever order you want. And there's really no limitation to the type of music you can play or the type of image acquisition you can acquire. It's really just a matter of your creativity in coming up with the order in which you play these different instruments. So with that, I'm going to pause. I thank you for your attention. And if there's any questions from any of the folks here at Houston Methodist on Zoom, I'd be glad to take it. Okay, I guess not. So then we will see you all next week. And thank you again for your attention.